everyone, my name is Abida Babu. I'm an incoming intern at USF. This is a video on chest pain, the algorithmic approach for an intern night officer when called in with chest pain, when to call for help, and how to identify the main cause of chest pain. When I'm called in with chest pain, the first thing that would run through in my mind is the patient hemodynamically unstable or stable? If the nurse tells me that the patient's unstable, then I would want to know, requiring to call a code. If they say yes, then activate the code. If they do not know, but they just know the patient is crashing, then call your nurse, let them know that you're on your way. In the meantime, ask them to order an EKG, drops, chest X-ray, ABG, and a fresh set of vitals. Once you've done that, on your way to see the patient, alert your senior so you can keep him or her in the loop. Now let's consider a different scenario where your patient is stable. You still want to do the same set of protocols. You ask the nurse to get an EKG, a fresh set of vitals, and assure them that you're on your way. Now once you go in to see the patient, your assessment starts the minute you see the patient. Is the patient in distress? Is the patient resting comfortably? If the patient's distress, before you go in, alert your senior. Let them know that you're going in to see the patient and you're going to do a physical, but just keep them in the loop. Now, if the patient's comfortable and resting well, then you want to know more about the pain. Ask for the description of the pain. What kind of pain is it? Is it a crushing kind of pain? Is it a tearing kind of pain? Where is the pain? Is it substernal, radiating to your left arm? Does it get better with rest? And was the patient emotionally distressed when the pain started? This will help us rule out if it's cardiac versus non-cardiac. Now, if you suspect it to be highly cardiac, in that case, order troponins, chest X-ray, and attach the patient to a telemonitor, because one of the main causes of mortality in an ACS is arrhythmias. You don't want that to happen. Now, while getting a description of the pain, you are doing a physical at the same time. The things you want to look for are the heart sounds, the breath sounds, and the extremities. And the heart sounds you want to look for are the heart sounds muffled. Can you hear an extra S3? Do you hear any murmurs, any rubs, any gallops? And in breath sounds you want to check, is it absent? And in the extremities you're looking for if it's enlarged. Are there any signs of DVT which could possibly cause a PE? Once you're done with the physical, at that time you would have an EKG in your hand. The things you're looking for is ACS, STEMI, NSTEMI, and an unstable angina. The way you see if it's a STEMI is you look for ST segment elevation about 1 millimeter or more in 2 or more contiguous leads, and in V2 and V3 leads if there is an elevation of 1.5 millimeter if it's a female, 2 millimeter if it's a male, or a new onset of left bundle branch block. In that case, there's no doubt it's a STEMI, alert your senior, and a cardiology fellow. Now, if you don't have any signs of STEMI, is there any ST segment depression, T-wave inversion that you think could be an NSTEMI or an unstable angina? You should again alert your senior because there is a set of algorithm that you want to start. Now, once you have ruled out ACS, you want to think of the next big killer, pulmonary embolism. About 30% mortality is seen in pulmonary embolism if left untreated. So the way you rule that out is, again, the quality of the chest pain. What kind of chest pain do you have? Because you want to rule out the other causes. And from the vitals, you can check, is there an increased heart rate? Is the patient tachypnic? Do they have any risk factors? Like, if the patient has had previous surgery, if the patient has had previous embolism, if the patient's on a female on OCPs, if the patient is a smoker, in that case, again, alert your senior and start a heparin drip or CT angio in coordination with your senior, do the required. Now, the other thing you want to rule out is aortic dissection. It's low in a differential, but it's still essential to rule it out. The way you do that is from the vitals that your nurse gave you. You want to check if there is a discrepancy in blood pressure on both arms, 20 millimeters of mercury or more. That's your first indicator. The type of chest pain, is it a tearing kind of chest pain? Is the patient wincing with pain? If the patient has any risk factors, is the patient hypertensive? Or if the chest x-ray that you ordered previously has any mild and mediastinum. Mind you, the chest x-ray is only 60 to 90% sensitive in ruling out aortic dissection. So if your differential is high, you still need to alert your senior. Now, if you're considering pneumothorax, is the patient, are the breath sounds absent on your physical, or is the patient tachypnic, and does the chest x-ray show complete blackout? Again, alert your senior. Once you've ruled out all the main big guns, then you can delve into the other causes of chest pain. So in this video, I have covered the algorithmic approach as to an internite officer when you get called in for chest pain, how to identify the main big guns, and when to call for help. I hope this was helpful.